topic, can everybody hear me okay? The topic of medical device security and application security, particularly following the presentations we just had, may seem like it's a little bit of an odd man out, but really I think the discussions that we've had up to this point with Dr. Schmidt and Liz, particularly talking about transparency in processes, of transparency in healthcare, transparency in, just like her example with Eli, around how does a drug get approved. We need to have more of a conversation around healthcare security as we start talking about freeing our data or broader use of our data. Is everybody here familiar with the concept, or you've probably heard ransomware lately? It's seen it about 100 times a day in recent news. Here's the one reason that this matters in terms of what we're doing. And before I back up, or let me back up just one second, about myself a little bit. I'm an information security consultant. I've been in healthcare security for several years, banking security before that. And my firm, we're an international healthcare, international information security services firm headquartered out of New York. Offices from San Francisco all the way to London. I'm over our healthcare security practice itself, and I'm actually down in Nashville, in terms of when we talk about ransomware or device security, this is why it matters. And this number should not be okay by any means, but this is the reality. 88% of all ransomware that is in the wild these days actually targets healthcare. As you can see, second, if you even want to call it second, is the education sector at 6%. There's really no surprise why. Those of us in security have been basically shouting from the mountaintops for years that healthcare security, and it doesn't matter if it's from the hospital side, because I'm going to talk equally about the healthcare technology side as well, particularly from manufacturers, developers, and vendors. Security in these sectors tends to be about 3 to 4 years behind other sectors like banking, manufacturing, and other areas. Here's something I want everyone to think about here. Everyone here has probably gone, somewhere, Best Buy, Target, bought a Wi-Fi router, taken it home. This is a page from a Netgear owner's manual, just a standard issue off-the-shelf router. And one of the first things it does in Chapter 2 is starts walking you through setting up security, the wireless security, WPS, MAC address, changing the admin passwords. What I want everybody here to think of is we're doing more these days to set up and secure a router in our home than we are a device that's actually hooked up to a live human being. Medical device security is a patient safety issue. Anybody who tells you that it's just malware or it's just about encryption, they're missing the point. These are devices, again, hooked to a person. They're providing not only diagnostic data, but they're also rendering services in many ways, or rendering a treatment to a patient. And malware is just one way that these devices can go wrong. And I think, again, we have to shift the conversation away from healthcare security, and particularly device and application security, to really look at the patient safety aspect of this. Because I think we focus too long on just simply trying to do things like meet HIPAA compliance, which I will get on a brief soapbox about that. HIPAA has nothing to do with security. If you say that you're HIPAA compliant, you're probably not secure. So any company that tells you that they are HIPAA compliant, there's about 20 more questions you need to ask beyond that to really figure out if they have any kind of security worth their name. In terms of in the healthcare space, a big reason why we're at this point now with healthcare security is that the safeguarding of patient records in terms of the spending has been disproportional on to safeguard records as opposed to safeguard devices and diagnostic equipment. Nobody wants a $2 to $3 million HIPAA fine, and we see these leveled by OCR, just about daily now, ranging from 10,000 up to several $1 million. But what's the cost going to be when you have a wrongful death suit at your facility because a single device has malfunctioned or been infected? And before I go on, also, is everybody here really familiar with why medical records are so valuable on the black market? Is there anybody here who doesn't understand? Okay. Medical records are actually the highest value target on the black market. The average medical record goes for about $50 on the black market versus $10 roughly for a credit card number or a social security number. And the main reason is insurance fraud and prescription fraud. People use it to file billions and billions of false claims annually. Second to that, you have a lot of information around family history and medical history. If you think about, your mother's history, grandmother's history, maybe there's some genetic information in there. Maybe the area you grew up in, city, state. And most of the time, this is information that you would see when you're trying to answer or challenge questions to reset a password. If you think about your mother's maiden name, what city were you born in? When you're trying to reset a password, a lot of times that information is also in the medical record. So you have a typical medical record. It's not that somebody really wants to know how your x-ray turned out. They want to start filing fraudulent insurance claims against it, and then other people want to then use that for identity theft. This is the typical ecosystem in internet health and the internet of healthcare, I guess you could say. And it really is as messy as it looks. You have, on one side, you have consumer devices, wearables, you have workstations, you have a public cloud. You'll hear me refer to AWS, which is Amazon Web Services, which most technology companies are using either AWS or the Microsoft Azure public cloud environment. Then you have, on the other side, at the clinical environment, you have workstations, you have mobile devices, you have the actual medical devices themselves, whether it's ultrasound, CT machine, or some kind of pump. And right in the middle, you have the patient at the crossfire. And what you'll notice here is that when you think about submitting your information, whether that's from a device, is sending diagnostic information to the EHR, or maybe you've got your phone collecting some information about you that is then now syncing up with some other application or patient portal. None of these are serial processes. These are all parallel processes that are going off in all different directions at one time. And so this is one reason that it is very difficult to really get a handle on how do you not only secure these devices, but how do you secure the data that's going back and forth between all of these devices. In security, everything we talk about, there are three tenets, what we call the CIA. This has nothing to do with the Jason Bourne CIA. It's confidentiality, integrity, and availability. Healthcare, I think, is concentrated too long on the confidentiality side. And again, that's because with HIPAA and meaningful use, we've had some requirements around encryption of data, the confidentiality of data. And really, when you look at it, most of the fines that have been leveled have had to do with disclosures, privacy disclosures or disclosures of confidentiality of data. And not just credentials, maybe from a clinician that allows somebody to get into the system to take the records, but then actual direct breach of the system itself. On the availability side, that's been one of the common themes here at Medicine X the past few years. This is the fourth year in a row I've presented here, and every year, we're making a more progressive argument and more progressive case for how data can be used outside of just the clinical environment. But as a security person, let me start applying what can go wrong from both the integrity and the availability portions of this. On the integrity side, you can have altered biometrics, altered or tampered dosages. And I'm going to give you an example that we had with one client in just a few minutes. You can have corrupted application algorithms, which in this case, when I'm talking about medical devices here, I'm talking about not just a physical thing, a pump or a CT that's connected to a person, but also the ecosystem of applications. Some are web applications, some are standalone applications that are either processing that data, analyzing it, providing metrics around it, or just simply providing sort of that pass-through or tunnel to the data. The security of those applications is just as equal as the security of the devices themselves. And then you start getting into availability. Again, this is where we're talking about kind of going back to the ransomware argument. Locked and deleted charts. You can have applications, whether it's PACS or other systems that then become disconnected from one another, down to actually disrupting the actual wireless infrastructure and telemetry infrastructure within a hospital itself, again, preventing sometimes very life critical decisions from being made because there's no communication or the communication has been disrupted. As I mentioned, we need to start talking about device security as more than just malware. This is an example of this was a very large client, one of the largest health systems here on the West Coast, and we were doing a security assessment and architecture review. And I took lead on this. And part of what we do when we're doing a security assessment is not just the information security and the IT security side of this, but physical security as well. Most healthcare-related breaches still occur either because of a lost or stolen mobile device or laptop or through a social engineering attack, phishing email, somebody picking up the phone call, or somebody walking in, literally picking up a box of records and walking out. So physical security is very critical to this. As we started doing our walk through the facility, I always ask nurses, how's it going? What's bugging you? Is there something going on that you think we should know about? And I started getting some consistent answers from different groups where they were saying, yeah, we're having trouble with our Pyxis machines, which those of you who don't know, that's the machines that are dispensing a lot of the different medications at the individual patient unit level. What we were able to figure out was that we had Pyxis devices in 3 separate patient units that were randomly rounding up or down dispensed dosages. So let's say 325 milligrams of acetaminophen. Sometimes it would randomly spit out 300. What these things are doing in these particular devices is they were actually, it was dropping a little plastic bottle, dispensing the pills, capping it, and then printing a barcode on it. 325 down to 300 for acetaminophen, it can be in the context fairly innocuous. But for those of you who are in pediatric units or treat children, a quarter of a milligram can be life-changing. And on top of that, in these same devices, these barcode printers would sometimes not even print that label for up to 30 minutes. And what the nurses were doing there is they would scan the bottle and then scan the patient's bracelet to make sure there was a match. In many cases, what was happening is as they went to that 30-minute, when they were in that 30-minute delay, they were having to resort to paper charting. The reason had nothing to do with malware. This particular hospital was about 6 weeks post-implementation of their Epic EHR. And one vendor, and if you know, we all heard the phrase, you had one job. This guy's one job was to write a script for Epic to talk to Pyxis. This particular firm, and it was a small firm, I think of 3 or 4 people, they had no change control processes, nothing that actually reviewed code, no set methodologies for how they were writing code and on this interface. And because of that, there was no checks on how it was working. So he implemented this script, and what it was doing is that script was causing these discrepancies. So when you think about device security, again, it's not always malware. Sometimes it's somebody, coding very poorly, or a device malfunction, or maybe a device malfunction caused by poor coding. In terms of some practical ways that we can actually start looking at within an environment, and I'm going to speak to things from both the clinical side as well as those of you that are on the healthcare technology side, because we do have a lot of clients that we work with in the healthcare technology space and application development and device manufacturing as well. One thing that we tell particularly our larger hospital or health system clients to do is take kind of a bank-like approach to vendor security analysis. Bank is a 4-letter word for a lot of people, and I get it. I used to work at one. But one thing that banks do really well when they're talking about vendor risk is they analyze not just the technology and the security of a given product that they're evaluating, but they also look at the vendor themselves, particularly the financials of the vendor. On the med device side and med application side, we've got to start looking more at upfront about hardware and software interoperability. Up until basically even in most facilities now, the purchasing process or the decision process to buy a device that goes into hospitals had exactly 2 steps. That biomed buys it and then Biomed plugs it in. And yes, we need to go to a more lengthier, more complex process, but the problem is you have so many devices in the typical hospital environment that are not only connected to the network, but also connected to a person in a series of applications that they have virtually no inventory on them and have no security profile on them as well. So if you don't security profile something, an application, a device, a process, or a company, you can't learn how to mitigate it. And then what we tell them is also look at the developer financials as well. You know, we've got, you know, my one beef that I have with a lot of the startup industry here in the Bay Area is that security is almost always an afterthought. And I get it. You know, security does not sell. Security doesn't get you that next round of VC funding. But security will bite you later on. And what we've seen time and time again is a lot of these smaller development shops that are particularly, not just in the healthcare space, but others, as they start either maybe not getting that kind of next round of funding that they need, but perhaps they've already sold their solution into a number of hospitals or a number of health systems, their financials start to take a nosedive. And as their financials go down, they start doing things like cutting people. And in development shots, sometimes the first people they cut are those that are doing any kind of QA work or database administration. And once you start cutting staff like that, your quality goes out the window. And when you have no quality, you have a poor product. And even then, as we tell them, look at the financials. If that company ceased to exist in a year, which there are a significant number of startups that do cease to exist after a year, have you put a process, a patient-dependent process in place in your hospital based on that application for something that may not exist in a year? And then just where banks look at business unit impact, we stress look at patient impact, not just, and when you look at a device or application, look at those with the highest security risk and then cross that against those with maybe that are going to have the highest number of patient impact. And when we say patient impact, we don't mean just volume of patients, meaning it could affect 3 patients, but if a malfunction of that device could lead to a fatality, then even one fatality is a critical patient or business impact. This is one of our clients that gave us a list of some devices to do some black box penetration testing against. This is actually just 12 devices off a list of 400 that they gave us. And even then, that 400 that they gave us were really the only ones they knew about out of approximately 3,000 devices on their network. You know, you don't know what you don't know. So what we tell people is inventory and profile everything. We also have another client, one of the largest children's health systems in the U.S. that has 20,000, literally 20,000 medical devices on their network. They know of maybe 2,000 or 3,000 of those. Again, simply because it has been, like most health systems, purchasing and implementation of these devices has been so decentralized that IT doesn't really know what's out there. And if you don't know what's out there, you can't mitigate and control from a security perspective. So what we tell people is, how do you profile a device? This is the starting list of what you should do. Is if you're looking at an application to implement into your environment or a medical device itself, look at, is it discoverable? Meaning when it pops up on the network, are you going to be able to know what it is, not just see that IP address? Making sure it's in your existing asset inventories. Looking at the OS version, you want to make sure it's not using a legacy OS. Documentation of SDLC or secured software development lifecycle processes, data encryption. These are just, again, these are the starting 7 or 8 points out of 20 or 30 that you need to gather about a device before it gets plugged in. If you'll notice, the last thing or the thing on here at the bottom is compliance with the HIPAA security and privacy rules. This is by design. Again, compliance does not equal security, and you cannot have compliance without full security. Again, a lot of firms say the opposite of that, but you know, ask any health system who has been breached in the past 10 years, and they'll tell you that they were HIPAA compliant before they were breached. So from a best practices standpoint, first thing you need to do is plan. Again, we talk about profiling all devices, all applications, prioritize compensating controls around them, look at the devices, particularly those with the legacy OS. And the legacy OS in this case would be anything, say, from an older version of Linux or anything from Windows XP down. What you'll find is that probably over half of all medical devices sitting inside of a hospital right now are running a legacy OS. And in general, these larger medical devices are probably the most, in most cases, they're the most insecure things sitting within a hospital's four walls. It is very, very easy, not just to, through a network situation, hack these devices, alter information on there, but also not just through the network, but also wirelessly as well. And the legacy OS is a big part of that. It makes it much easier for malware to propagate and get into the system. Every hospital and any clinical environment needs to have an incident response plan in this day and age. And an incident response plan is not a disaster recovery plan or business continuity. But your plan should include how do you isolate and compartmentalize either devices or a block of devices if there's either an infestation event or if there's a malfunction event as well. Again, malfunction is just as critical as infestation. On the application side, as with our example with Pyxis, interoperability and app scripting flaws. Any kind of, and we talk about the integrity and the availability portion of security. If you're messing with that, you see a situation like what we have with the Pyxis machine where you had a bad script, was passing along bad data, and it was actually making decisions. That script was essentially that it shouldn't have. It should have just simply passed that number along. When you're in a maintenance mode, change control and rollback processes. Let me go back to my example about the Netgear router. You've installed that Netgear router now. Are you going to let somebody from Netgear or Best Buy, Geek Squad, whoever, come into your house without your knowledge, hook up to the router, enter in their own little super secret password, do some patching to it, and then leave without telling you? But that's exactly what goes on every day in most hospitals. You know, these devices are typically managed by the manufacturer or somebody who is providing support for that manufacturer, whether it's GE, Siemens, Philip, or whoever. And in most cases, this is exactly what they do, is some guy comes in, checks in through RepTrax or VendorMate, hooks up his laptop, patches it, and then leaves, and the facility may or may not even know that he was there. And 99% of the time, they don't know what he did to it as well. So this was the part that really we have to force change from the legal and compliance side. For those of you in a clinical environment, get with your general counsel and your chief compliance officer to really start pushing more transparent change control processes and versioning processes from the manufacturers and from these vendors. Again, look at an application as a device as well. It's going to be handling either diagnostic data or sensitive patient information as well. And then on the ransomware side, there are a lot of decryption tools out there. A lot of people are trying to sell decryption tools to say, hey, if it gets infected, we've got this thing that will decrypt it. Don't depend on those. They're not a fail-safe. They work in maybe 15% of all situations. And again, from the compliance side, like we mentioned, go back to the drawing board with your business associate agreements. And those of you on the technology side, be more forthcoming and do better in your agreements and the things that you're doing from a security perspective with clinicians and with facilities. And those of you on the clinical side, again, analyze the financial stability of the manufacturer and the developer. It has a direct impact on the quality of that device or of that device or that application, as well as you don't want to be left hanging with an application or device hooked up to a person later on in which you have no support for it. And if you have no support for it, it's not going to get patched, and it's, from a security standpoint, it's a minefield. And then before you even plug in a device, create an end-of-life process for that device. You want to do things like, in your agreements, you want to make sure you have full data custody, for example. So when that device is end-of-life or that leasing agreement has ended, make sure that you have full custody, retained custody of all the data that's in there, not the manufacturer. You'd be surprised at in how many cases that hospitals have to play tug of war at the end of the process. And I say all this stuff around, in IT, particularly, we talk about profiling, developing incident response plans. there does have to be more of a collaboration between legal, compliance, IT, and then the patient units on this. But what I want to get across also is that as IT and compliance start really driving these processes, their job is not to make a decision about whether or not to buy this device or use this device. The purpose of doing all this is twofold. It's one, provide decision support for that patient unit or that clinical unit. And second, it's when that unit buys it anyway, even now, you're now at least armed with all that security knowledge to be able to kind of wall it off or mitigate the risks associated with it as best you can. You know, the reality is that you can put in the best processes and everything else, but you're always going to have that one, you know, rock star cardiac surgeon who has to have this thing right now because it's shiny and it's going to help save additional patients. And I want the doctor to have that device, but we have to balance innovation with a sanity check around security and realize that these devices, this is not a Porsche on a dealer lot. This is something connected to a human being. And the last point I want to make to really sum all this up is, you know, all of us on, whether it's e-patients, clinicians, physicians, nurses, you know, we all know that we are part of patient care. We are directly responsible for patient care. Healthcare technology companies, device manufacturers need to get this through their head as well, that they are just as responsible for patient care as anybody that's sitting in a hospital. Again, what they build and what they're coding is going to be affecting the life of a human being directly. And that's it. Do I have any questions? Yes. It's the healthcare space. It's a little too far off. I mean, because they're having trouble just playing catch up with what's been going on the past 3 or 4 years. We're already having that discussion though about how that affects kind of the future technology life cycle. But in most cases, they're just simply playing catch up still at this point. I do think blockchain has both some pros and cons from a security perspective though. Yes. Find out what I would tell you is, you know, it's not unusual, or it's typical these days. Especially when you're finding a physician, you know, people go and look at even down using tools like Yelp and others to kind of look at physician ratings. Find out when you can, and I realize it is in some cases it's a stretch, what devices they're using. What's, you know, is it a Baxter pump that you're hooked up to, or whatever, and then just go out and look. I mean, it's, you know, that's what I want to get across is that on the patient side of understand what is hooked up to you. I mean, there is, you know, we have, for example, proof of concept where we can hit an infusion pump and have it deliver 4 times the lethal dosage of chemo and back out without a trace. You know, you as a patient need to know the security risk of that. When you buy a car, you look at the recall notices on it, or what's the safety record of that car or that manufacturer. We have to have more disclosure from both the hospital side and the manufacturer side about the same things. Yes. Yeah, so what I'll tell you there is, as much as the FDA says they are and really wants to have more regulation in place, they can't. There's, you know, the horses have been let out of the barn in this case. They have issued, you know, more recent, you know, a little bit more strict worded guidelines around it, but there's only so much that they can do, because when you look at it, they're not directly governing, for example, the thousands of healthcare apps that are on the iOS app store, and they're excluded. But here's the problem with that is those third-party apps in many cases are the ones that are going straight into a patient portal or going into an EHR, and the problem there is most of those applications were developed offshore, most of them with questionable software development and secure development lifecycle processes, if they even used a SDLC methodology in the first place. And even when you're using that application, you know, this isn't, you know, a lot of people think, okay, like Map My Run. It's gathering all that data and then it just goes straight into the app. what most people don't realize is all these applications like that, your data gets bounced around the world. I mean, that data is going back to China, going back to India, going back to Eastern Europe, somewhere, a data center there or that original developer for purposes of advertising analytics or maybe under the guise of QA. But the reality is there's never a straight line between your wearable and your phone or your phone and the hospital system. And that's the part that really that the FDA has to crack down on. Now, we do a lot of work around international security regulations as well. So we have some organizations in which we work with them, for example, on a cloud, their healthcare application and different cloud architectures for different regions of the world. So, for example, to comply with the security regulations and privacy regs in Japan, they have to have almost a pure private cloud environment. Whereas Canada, North America, and the U.S., we can have a pure public cloud on AWS, and then Europe, it depends on which country you're dealing with. So what's going to have to happen is you're going to have regulations down to almost the country level on how that data can get bounced around. I mean, we really don't have safe harbor anymore in EU. It's being replaced by the Privacy Shield and then a lot of kludgy individual country regulations. But you're going to have, I think you'll end up needing to see the FDA putting something like that in place for U.S. consumers on data needing to go to staying within our shores or staying in certain points here, because you're also starting to see, like even us with our hospitals, we tell them every application vendor you deal with, every manufacturer or device manufacturer, ask them if any of you, not just are they using offshore development, but is any of their data being used offshore as well, bouncing around for whatever purposes. And those are the things that the FDA can control. But yeah, I do worry about things from an integrity standpoint, a quality standpoint. Most physicians will tell you the same thing. And even then, the more the new technology we have makes it easier. I mean, we're moving towards a system like an Apple Pay type thing where you tap your watch and it's instantly downloading into the EHR or to a portal. All it takes is some kind of zero-day vulnerability to go in, and you've now propagated within that hospital network in a matter of minutes, based on just, again, tapping with either Bluetooth or NFC capability. So, yeah, again, going back to all the sanity checks between security and innovation we have to have, because the integrity of the data is a major issue. I mean, just think about, and as you all know, just with, say, an iOS device or your Apple phone, you can run 5 different apps on there to count your steps, and you'll get 5 different numbers off of it. That's all you need to know about it. Now you amplify that out to actual real biometrics, and it gets scary. Yes? Yeah, we do. And, I've actually started working with a group in Nashville. It's the Center for Medical Interoperability. And that's one of the missions there, is because that is the reality, is because any time you start dealing with changing something from one format to another format, you immediately have integrity issues. And yeah, and so those of us in security, that's one thing we've been advocating for a very long time, is to have more standardized exchanges of data, standardized formatting of data, so that, again, like in the case with the Pyxis and Epic, you don't have to depend on something sitting in the middle to interpret that data. It really should just simply be passing along the data. Yes? Yeah, and that's exactly why yeah. Yeah, and yeah. Well, yeah, and like that's my firm. That's a lot of what we do for hospitals. And like in the case with device security, one thing we do is we go in there, and besides helping them stand up a vendor risk management program where you can profile these devices, again, you're dealing with thousands of devices. So what we've done is put some statistical methodology around that profiling. Just let's say you have 3,000 devices. What it does is it helps isolate those, say, top 5% of devices that have both the highest security vulnerabilities and the highest amount of patient impact. And then from there, we do black box testing against that subset of devices. Most hospitals, you can't even make if you're in IT, you can't even make a sideways glance at the inner workings of that device, because in most cases, or in almost all cases, maintenance and updating of that device is solely on the manufacturer or somebody that they're using for support. And in many cases, the SLA prevents hospital or hospital IT from even logging into the device from an administrative standpoint. And so that's why we have to then essentially kind of do an end run around that and do black box testing against the devices that we've identified as the worst offenders. And I'd say well over half the time they do come back with critical vulnerabilities. A lot of the very large devices like CT machines are some of the worst offenders, really. Anything that is running essentially its own both operating system and application ecosystem to operate the device, those tend to be some of the worst ones. But even then, something like a pump, which doesn't have an application at the front end of it per se, most of those are going to have, they have both Ethernet connectivity as well as Bluetooth and Wi-Fi connectivity. And so we're also analyzing, doing traffic analysis of the data going to and from there, because it may not have an application controlling it, but if it's sending out patient information in clear text, then that's a problem. And that's a lot of the testing we do around the device side is looking for things like that, as well as when we're doing just security assessments or technical security testing as well. We're looking at data traffic analysis of everything going on within the hospital network, and then that also allows us to pinpoint kind of those hot spots, whether it's a server or a device. Okay. All right. Thank you, everyone.